All right, for this lecture bite, we are going to cover antiviral agents and that is going to cover oh, and tuberculosis. That's what I couldn't remember. I was like, there was something other than virals. So we have antiviral agents, and we're also going to talk about the treatments for tuberculosis, which I could have put in the PowerPoint with antibiotics, because technically it sort of does fall under that. But there's just a lot of material in the antibiotic PowerPoint. So I have included it in this one. So we're going to talk just a little bit about the blood since viruses are predominantly, they oftentimes they can be acquired. A virus can be acquired through blood, but not always. But we're just gonna, this is just a place where they put that information. So we're gonna just go over the components of the blood, explain the pathophysiology of HIV and AIDS. We're gonna talk about oral manifestations, talk a little bit about the treatment for HIV, AIDS, and then a little bit about tuberculosis symptoms, pathophysiology, a little bit about the treatment, some other viruses, the herpes simplex and hepatitis A, B, and C, and then also talk a little bit about treatment for just sort of other viral types like the flu and things like that. So what is in your blood? So we're just going to do a very brief overview of the components of the blood. About a little bit more than half of the blood is made up of plasma, which is water, ions, vitamins, and waste products. That's what is consists of the plasma. We have the platelets, or the thrombocytes, that's involved in clotting. So it can be a good thing if you have a cut, and it can also be a bad thing if things are clotting too much, you have buildup. So they are suspended in the plasma as well. Platelets produce tiny fibrin threads, form a web-like mesh, and trap the blood cells, and that's how you get that clot. And then there's the red blood cells, which make up pretty much close to the other half. It's mostly plasma and red blood cells is the main makeup of your blood. And then we have the white blood cells, which is our immune function and sort of the little phagocytes that eat the things that we don't want, waste products or maybe cells that are not formed correctly. But so 42% of the blood is the red blood cells, carries and transport carbon dioxide and oxygen, contains hemoglobin, oxygen, carrying molecules. There's no nucleus, it's just that donut-shaped cell. And there's a lifespan of 120 days. And that's where that HbA1c, where they test the blood glucose, because these cells, these red blood cells hang around for roughly 3 months, they can get a longer snapshot of what somebody's blood glucose readings are over the course of several months, as opposed to just like a moment's reading. And I just wanted to highlight that, even though we're not talking about diabetes, but since we are talking about the blood and the lifespan of a red blood cell, I wanted to connect that back to the A1C reading that we get from our patients who have diabetes. So, white blood cells produced in the bone marrow, and that's our immune system functioning. That's made up of granulocytes, lymphocytes, and monocytes and macrophages. Our lymphocytes are our B cells and T cells, very important in the immune response, and they also produce antibodies. Granulocytes are 90% neutrophils, and they defend against foreign stuff that's not supposed to be there. Bacteria, eosinophils, and basophils make up the last 10% of the granulocytes, and they have a role in the inflammatory response and allergic reactions. And then the monocytes and macrophages, they have just diverse function. I'm not going to test you heavily on these components. It's just more to kind of familiarize yourself. That's not to say that you might not have some of this stuff in the national board. When you go to take the national board, some of this stuff could appear on the microbiology and those sections of the national board. So um, hematopoiesis or the blood formation. Again, I'm not going to test you on this. This just goes through the flow chart of how all these cells sort of differentiate. Um, the normal for the white blood cells, a normal range is 4,400 to 11,000. Um, Oh, I can't remember what the MM3 stands for. I had it. Oh, I have it in my notes. Cubic millimeters. I knew I had it written down somewhere. And then for leukocytosis, high levels of leukocytes is anything greater than 11,000 cubic millimeters. Possible causes, you maybe pregnancy can elevate that. Exercise, emotional stress, infection can make your white blood cell levels go up. Say you have a UTI or something like that. Leukopenia, lower levels of leukocytes would be under 4,400. And of course, then they'd be worried about something toxic. Maybe you're taking a chemotherapy or getting cancer treatment and it suppresses your white blood cell count. And of course, also early leukemia. So that's just a very quick, very brief overview of the compositions of the blood. For viruses, viruses can be difficult to treat with medication. Very oftentimes when somebody has a virus, if it's like a viral infection or something like that, they're told to just basically write it out. There's different viruses that kids get that really have no treatment at all. They just have to write out that virus. Viruses do need a host to live and replicate, and they do not have their own machinery for reproduction. That's why they need a host. Medications that kill viruses will often harm the host, and so that's why there's not a ton of like good pharmacological treatments for viruses. We do obviously have a few, but not nearly as much as for other conditions or bacterial infections or even fungal infections. So one virus that's super common is the herpes simplex. Oftentimes it's associated with what we call a cold sore. Dental practitioners may be asked for something to help with this. So it's right around the mouth. You might see your patient with a cold sore. They might start to feel one coming on. They might ask you for advice on how to treat it. And there's just a huge laundry list of things that people do. They talk about avoiding certain foods. Some people ice them when they feel that prodromal stage come on. There's different supplements, lysine. Some people take heavy doses of lysine. There's just different things. We can also use our laser, our diode laser. It works the best if it's an early stage of a herpetic lesion to try and help it heal up faster. And then there's the antiviral, systemic antiviral medication, and also the topical that we'll talk about. Um, the most antiviral agents are either purine or pyrimidine analogs that inhibit the DNA synthesis and that helps to shorten the lifespan. So for herpes, it's a virulence capacity to invade and replicate in the nervous system. It tends to lie dormant in this trigeminal ganglia, and a third of individuals will have the virus for a lifetime. Other people clear it. So there's studies that say like 98% of people have come in contact with the herpes virus, but a large percentage of people clear the virus and don't ever show signs of or symptoms, whereas some people will get, recurrent lesions on a regular basis. Um, Oftentimes in that primary infection, that first infection, you'll get acute gingivous stomatitis, very painful, very uncomfortable. Usually you're young when you get it, and so you might not remember. Fever, malaise, nausea, vesicular lesions, gingivitis. These are all common. Viral shedding can continue in the saliva for 3 weeks after the visible sores are gone. So it's really important that patients know that. So they have to be cautious about their interaction with other people after they've had a cold sore. especially if it's somebody like new in their life. Subsequent outbreaks vary with individuals, not as severe as the initial occurrence. So that initial occurrence can be very painful, very bad, and then subsequent ones typically are not as bad. Medications, acyclovir or Zovirax, it inhibits DNA replication, lessens effects, preferentially taken up by the infected cells. Side effects can be headache, central nervous system effects such as dizziness or a funny taste, nausea. Treats broad spectrum herpes simplex 1 and herpes simplex 2, varicella zoster, Epstein-Barr, and others. So chickenpox and anything that's in that same family. Then there's the topical Dacosanol or the Abreva. It's a topical over-the-counter cream. And then there's Valacyclovir or Veltrex is the brand name. And that's primary recurrent herpes in immunocompromised patients. So if somebody has maybe HIV or AIDS, they may need to be on something like a regular regimen to help with the reoccurrence of the virus. So acyclovir and valacyclovir may be prescribed in a preventative form or a daily dose if somebody breaks out. Maybe they have like genital herpes or something and they have recurrent outbreaks. They might be prescribed this on a regular basis. For oral considerations, elective dental and dental hygiene treatments should be deferred for patients who present with active herpetic lesions. So elective dental and dental hygiene treatment, that means it's not an emergency. They can elect to have it done or they can elect to not have it done. And so if somebody has an active lesion, you need to postpone prophies, radiographs, anything that stretches or manipulates the mouth that could spread that lesion. Treatments may be uncomfortable and the patient is at risk of spreading the infection or becoming reinfected. Oral health professionals are at risk of infection through the aerosolization of the virus during dental procedures. So if you use the ultrasonic cleaner, the little viral particles can float through the air. Lasers can be used as an in-office treatment, and we will learn more about that toward the end of your perio class. And then you'll get hands-on practice as well over the summer. So influenza or the flu, it's contagious respiratory illness caused by influenza virus, influenza A, influenza B, all H1N1, there's all kinds of different viruses. Cold symptoms come on gradual. Has a sudden onset. COVID-19 seems to be either gradual or sudden. Roughly 8% of the US population gets the flu each year, although anecdotally, I will say I think it's much higher this year. But when my husband was in the emergency room for his leg, all I could hear was the nurses and doctors telling everyone in there that they've never seen so much flu in their whole careers. So definitely there seems to be more flu in this year, 2025. But in general, it usually runs somewhere around 8%. Complications of flu can include bacterial pneumonia, ear infection, sinus infection, worsening chronic medical conditions such as congestive heart failure, asthma, and diabetes. Some treatments, Tamiflu is an antiviral for the flu, a mechanism of action, influenza. Let's see if I can pronounce this. Neuraminidase inhibitor. So it basically goes in to some kind of an enzyme element of that virus and inhibits it so that it doesn't have the ability to replicate. Treatment or prophylaxis generally reduces the duration of the flu by 3 days, but it really has to be given early. If it's not given in like when the symptoms are first coming on, it doesn't seem to be as effective. Paxlovid is a protease inhibitor that they developed during COVID-19. It's still under emergency use authorization, I believe, but I should probably double check that. And then side effects, dysgeusia, diarrhea, hypertension, malaise. And then anecdotally, I have heard that rebound for COVID-19 is high with Paxlovid as well. Okay, so now we're going to shift to AIDS or acquired immunodeficiency syndrome, HIV, human immunodeficiency. AIDS is a chronic disease produced by infection with the retrovirus human immunodeficiency virus. We will review this again when we go for special needs. It's an opportunistic infection, often occurs in patients. Um, I'm sorry, I read that wrong. So opportunistic infections often occur in this population. So a lot of the time, what they're managing with a person that has either AIDS or HIV are those infections that happen because the person is immunocompromised. So they may be taking various anti-infective agents to prevent diseases such as tuberculosis, pneumonia, herpes, candidiasis, all these different things that in general, a person with HIV AIDS is going to be more susceptible to. The first cases were in the early 80s. End stage of the infection is HIV, but nowadays they control it so well with medication. Most people don't develop the AIDS, which is the end stage. They usually stay in the HIV phase. So, virus attacks the body's immune system, resulting in life-threatening infections and cancers. And that again was seen much more often in the early, the late 80s, early 90s when they didn't have as good of a treatment. Now, I show this slide again when we talk in special needs because I like it so much because it talks about the life cycle of how the virus replicates. It kind of shows like the exposure to the initial HIV virus, how it enters the cell, how it dumps its genetic material, it gets into the DNA, kind of hijacks it, spits out this other, these other um, products, which then are able to replicate and make more and more of the initial HIV virus. And so it's just this ongoing, it turns your cells into a machine to make HIV cells. And what I like is this 1, 2, 3, 4, 5, 6, 7. It shows the medications and where they interfere with this whole process. So we have, they stop this process here, post-attachment, and they prevent the HIV cell from attaching very well to the CD4 receptors. This one is a fusion inhibitor. It prevents the virus from sort of fusing with the cell and dumping its genetic material. We have the reverse transcriptase, the non-nucleotide reverse transcriptase inhibitors. We have the integrase inhibitors. We have the protease inhibitors toward the end. So this just goes and shows all these different medications that are used in these different stages of the life cycle of the HIV virus. So the pathophysiology of primary immune cells involved are the T lymphocytes, the CD4 cells, and I highlight that because that oftentimes is an exam question. HIV is a transmissible RNA retrovirus. It hunts for those CD4 cells because that's what it uses to basically replicate itself. Once inside, the cell uses an enzyme, a reverse transcriptase enzyme, to alter the host DNA and hijack it, like I said. The proviral DNA enters the nucleus, and then it just keeps making copies of the HIV using that CD4 cell. Decreased CD4 T cell count occurs as the disease progresses and the risk of opportunistic infections. So we have just an example of them: tuberculosis, various fungal infections, pneumonia, diarrhea, meningitis, cancers, specifically Kaposi sarcoma or non-Hodgkin's lymphoma. Those are two cancers that HIV AIDS patients are at much higher risk. The amount of virus in the plasma, the viral load, increases as the CD4 count decreases. So once somebody has a CD4 count that is below 200, that changes their diagnosis from just having HIV to having full-blown AIDS. So as far as the medications, which is predominantly what we're supposed to be focusing on, one thing I'd like for you to really pay attention to is the suffix. Notice how a lot of these end in VIR. So a lot of times you will know that you're dealing with an antiviral, and that's not just for HIV, but also for whether it's for herpes or any of these other ones, if it ends in VIR, you know it's an antiviral. So that will help you in answering some of your questions about drug identification. I just put there's many drugs in this category, and usually people are taking a cocktail. They usually call their group of drugs that they take the just heart highly active antiretroviral therapy, and they usually take m multiple drugs, or it might be like a cocktail of different drugs to help suppress the HIV replication. So for the NRTIs, we have tenofovir or Viride. For the nucleoside reverse transcriptase inhibitors, we have Sustiva or efavirenz, and notice the VIR is in the middle, not at the end. Protease inhibitors, entry fusion inhibitors. And I'm not sure why these are not red, but maybe these are the only ones that I test on. I can't remember why I made those red and not the other ones. Um, Thinking about the exposure, people in dentistry have to be aware of the risk, but know that it's very, very low. HIV transmission is approximately 0.3%, so less than 0.5% per exposure. So if you got stuck with a needle or with an instrument, needle might have a slightly higher because it's hollow. It can carry blood inside the needle, but an instrument is less risky because it's not oftentimes as the instrument maybe pokes into your skin, it sort of cleans off the edges, whereas a needle or if you're delivering local anesthetic and it has some blood inside the needle, that can carry a higher risk of transmission. But if you do have a needle stick or an instrument poke, and you know that the person can be verified to have HIV, you'd start prophylaxis within 72 hours. And there's current guidelines, there's certain medications that you take for a certain amount of time. Now, if the person that you use the instruments on a person, you can have them tested for HIV and it comes back negative and you can do those tests very quickly, then nobody has to take any kind of medication. So that's the biggest thing is if you do get a needle stick or an instrument poke, knowing your patient is like the biggest thing because if you know them and they can get tested, or you feel confident, that they've been tested or then all the fear comes out of it. It's when you're dealing with a bunch of instrument, you get stuck and you don't know whose those instruments were or where the needle came from. And that can be more of a high stress situation. But that's why we're so sort of safety oriented. We don't want anyone to be in a situation where they're fearful or would have to take the prophylaxis. Okay, we're going to jump over to chronic hepatitis. Hepatitis C, most at risk for the development of chronic hepatitis, and the treatment is protease inhibitors. For hepatitis B, it's very treatable. Usually there's a nucleoside or nucleotide analog, some kind of a medication. In general, hepatitis is characterized by inflammation of the liver. That's the itis is the inflammation and hepa is the liver and can cause either no or very few symptoms. However, it often leads to jaundice, anorexia, malaise. Hepatitis is considered chronic when it lasts more than 6 months, and then drug therapy can last for years to indefinitely. It just depends on the person and the case and what's going on. Typically, medication is tolerated, and many of these drugs are antivirals in general and end in this VIR. And I just wanted to point that out you can see it here, you can see it with the HIV drugs, and you can also see it with the like this drug here, this drug there. Almost everything that's some kind of an antiviral has the VIR. So that kind of, if you don't know the exact drug, if it asks you like which of the following is a AIDS drug, then you can whittle it down by noticing that suffix. Um, Okay, so last little section here, couple more slides on tuberculosis. It is a bacterial infection, so I really want to stress that because that can be confusing because we're in a antiviral PowerPoint. So this, like I said, normally this should be probably added to the other PowerPoint, but it just makes the other PowerPoint so long, so that's why it's over here. And it's also an infectious disease, and so it sort of kind of goes along with the viruses because we think about protecting against HIV and hepatitis B and all this kind of stuff. And so we also think about tuberculosis in the clinic and protecting ourselves from that. But it is a bacterial infection. So I highlight that because you could be asked that on an exam. It's caused by the Mycobacterium tuberculosis. Name indicates its formation of firm nodules anywhere in the body. It does predominantly kind of hang out in the lungs, but these nodules, these tubercules, can form throughout the body. A microorganism is inhaled through the aerosol droplets. Somebody really needs to be around an individual for a sort of a long-term exposure. You don't just like get, someone cough and then you get tuberculosis. Like you have to be around them for a while to get to have it um, passed on. So number of organisms inhaled and then the immune system is determined whether or not the person contracts TB. Individuals may be exposed but show no clinical signs. For the pathophysiology, can infect any organ, but most commonly the lungs. Droplets are carried into the alveoli, defenses control and contain the infection, resulting in latent tuberculosis. That means that those signs and symptoms don't always show up right away. If not contained, granulomas form, eventually causing necrosis. So back in the day when people didn't get treated, they could die from tuberculosis as the disease progressed. But good news, as a rule, close, frequent, or prolonged contact is needed to spread the disease, so it's not super easy to catch. 4 to 6 weeks after sort of prolonged contact, someone may experience fever, chills, GI upset, night sweats. Later symptoms when somebody has had active TB, especially if they're not getting it treated, weight loss, nausea, vomiting, headaches, palpitations, and that productive cough, sometimes with a bloody sputum. I just put in this clip because that movie, oh my gosh, now I can't think of the name of the movie. Someone will remember it. It was a really good movie. But Val Kilmer played Doc Holliday, and he was an American gambler, gunfighter, and he was a dentist, and he contracted um, TB from his mom. So all throughout this movie, where Val Kilmer's the actor, he's basically portraying, it's like, you know, not necessarily announced, but he's portraying somebody that has tuberculosis. He's looks worse and worse as the movie progresses, and he, is coughing, and he just looks ill. So, I think this is a little clip of some scenes where he's sort of showing some signs and symptoms of tuberculosis. So treatment, pharmacological management, people using anti-tuberculosis agents often do not take them as prescribed. And the reason is because you have to take them for a very long time, like 6 to 9 weeks, I think. And then, or is it months? Hold on, let me check. Oh my gosh, do I not say it anywhere? Oh my gosh, it is 6 to 9 months. I saw it in my notes. So they have to take it for a very long time, and people start feeling better. And when you don't feel bad and you have to take a antibiotic or a strong medication, people don't always comply like they should. So there have been development of multi-drug resistant tuberculosis drugs that's continued to increase because of the spread amongst people that are at higher risk, immune compromised, among the homeless. There can be higher rates in other countries. So with immigration, possibly it brings in new cases of tuberculosis. Vaccine, unpredictable for the efficacy. There's really not a tuberculosis vaccine that I am aware of. If somebody has active TB or signs or symptoms of TB, absolutely do not treat them in the clinic. Duration of therapy is based on a drug regimen, must be long enough to eradicate the disease. These are the two main drugs that you want to know for TB, isoniazid and INH. It's for both active and inactive TB, and rifampin, it's for active TB. These are some other ones as well, but these are the two main ones that I want you to know. Highly specific for Mycobacterium, side effects vitamin B6 depletion, hepatotoxicity, so liver toxicity, and then for rifampin, activities against Mycobacterium tuberculosis, several other species and non-tuberculous Mycobacterium as well. GI side effects are most common, and it can turn the saliva red or orange, which is kind of weird. So that's it for this lecture bite, and the medications in this that you would want to try to at least memorize into the categories would be the ones that are in red. So anything that's in red as we go along, those are the ones that would be fair game on an exam. So knowing these are drugs that can treat HIV/AIDS, and these are drugs that might treat herpetic lesions. And so that's why those are red. So you want to pay attention to those. And that's it for this lecture bite.